Good morning everyone, my name is Colleen Lenihan. We will begin by acknowledging the traditional custodians of the lands and water of the Gold Coast, the Yugambeh people, and pay our respects to their elders past, present and emerging. The presentation today is about refugee children now living in Australia and the psychological effects they have suffered being subjected to conflict-related violence in war zones like Afghanistan. As seen on the roadmap, the refugee children suffer from psychological trauma, so need a trauma-informed, recovery-oriented practice to help them recover. There are barriers in implementing this practice, recommendations to overcome these barriers, and an assessment of why these recommendations are needed and their benefits. The context of this talk relates to children 3 to 5 years of age in daycare centres in Queensland. The traumas suffered by refugees include repression, violence, war, displacement and persecution. Everyone's responses to these traumas are unique. For children, the resultant daily stresses can include vivid and intrusive memories and nightmares, which can then progress into common mental illnesses like anxiety and depression. The symptoms for these illnesses include headaches, fearfulness, tiredness, anxiety, depression and sleeping disorders. Childhood trauma impacts the development of sense of self, personality style, stress tolerance, capacity and the ability to form healthy relationships, so early intervention in daycare centres is crucial. Barriers to overcome interventions in daycare centres include inappropriate environment and language. Trauma-informed recovery-oriented practice stipulates the environment needs to be welcoming, safe and appropriate for the needs of the traumatised child. It is specifically designed to be a place of physical, emotional and psychological safety for everyone. Many refugee children have limited language development, which often creates misunderstandings, leading to feelings of isolation. Therefore, language is taught intentionally and through play, since research shows that play expedites linguistic improvements. Language and trust barriers can be overcome in a non-judgmental climate of acceptance. Literature recommends 3 specific evidence-based practices. Firstly, imaginal exposure therapy, because it specifically supports trauma-informed recovery-oriented care of refugee children. It gives them the opportunity to cope with the trauma until emotions triggered by it have lessened, giving them control over the memory and triggers. In a daycare centre, this is very important. An anxious or fearful child may physically harm other children and educators during an emotional outburst. The problem could also be alleviated by modelling from peers with lived experience. Secondly, play therapy is a very good adjunctive therapy for refugee children. It helps a child work out new and creative solutions to their problems at each developmental level as they explore their environment and continue to engage in therapeutic play throughout the day. Thirdly, trauma-focused cognitive behaviour therapy is recommended in daycare centres. It achieves autonomous recovery using child-selected trauma narratives like drawing, music and dance to confront and master the trauma. And they're also available throughout the day as part of the daily program. There needs to be change in organisations. Organisations need to become much more supportive of the families of traumatised refugee children and the professionals who help in healing and recovery. In order for these children to be assessed, the families need to go through a checklist with the leading educator who deals with that child. The organisation must have a room available so both parties are able to concentrate and honestly answer the checklist to determine the child's needs. When the therapist attends the centre to have inclusion support sessions with the child, another area needs to be available. The traumatised child needs to feel comfortable to develop a positive, trusting relationship with the therapist. She in turn needs to be able to share various strategies with the child so she can learn to exchange harmful thoughts with realistic, positive ones. Training for board members helps them to understand why environment of the centre needs changing. The staff needs specialist training to become more trauma-informed, recovery-oriented, aware, so they can meet the individual needs of the child, their family, possibly the community and the therapist. There are 2 specific changes in policies and procedures which would be useful in a daycare centre. Generally, children are only allowed in the parts of the centre which have closed-circuit television systems. An amended policy could be put in place where a child can be in a room without a camera with director approval. A policy also needs to enable teacher time away from her class. This enables collaboration with the therapist about how the child is progressing, strategies for best outcomes for the child, and how the teacher can continue the positive outcomes of the therapy through her programming. An example of this would be for a refugee child who has outbursts of emotion from unknown triggers. The therapist would help the child recognise negative emotions and use strategies to deal with them. The teacher would reinforce this by asking the child throughout the day how they were feeling and encouraging the child to use her words if possible. During group class sessions, they could focus on emotions, how they look and feel, and what strategies they can use with specific emotions. There need to be changes in professional practice. In order to successfully utilise trauma-informed, recovery-oriented care for the traumatised child, the teacher would need to be fully trained. This would enable her to be aware of different traumas, recognise the signs, respond appropriately, and avoid re-traumatisation. Self-care needs to be addressed so the teacher does not succumb to secondary trauma or compassion fatigue. This would involve education and thoughtful planning by the teacher. It could also be included in the program for the children to learn. An assessment of all 4 recommendations is as follows. A. All 3 therapies validate the child and can be used simultaneously if it suits the child and parent because the healing rate is faster when everyone works as a team. To have the therapy sessions in the centre and then be followed up by the teacher is ideal. This is providing the appropriate environment and toys are available and all professionals are collaborating. Procedural teaching should be limited and time needs to be programmed for the traumatised child to be able to play out her emotions. This is an extension of play therapy, enabling the refugee to express herself in creative ways, like drawing, dance and music, with a variety of resources, space and time. To employ a professional therapist as part of the staff within the centre would be the ideal recommendation. Changes in organisation attitude is vital. The 2 questions, what can we do and how can we help you, should be asked of all stakeholders. The therapist needs a complete cooperation of all staff at the centre. The teacher needs support and encouragement, which could be through a mentor or the educational leader, and the child can be communicated with either verbally or through meaningful interactions. To make a room available for interaction between the teacher and the traumatised child's family as well as the teacher and the therapist is doable. It could mean making a room more multi-purposeful and to have a booking system so there are not any miscommunications with who will use the room and when. Also, the child and therapist could use a specific room or a secluded part of a larger area. C. The changes in policy and procedure to install cameras in all rooms rather than just the classrooms would make the whole centre available for use. This would alleviate any breaking of policies and procedures. Changes in professional practice occur because evidence-based research shows it as an evolving practice. Including integrated care enables all stakeholders of the refugee children to see their strengths and needs, encouraging self-efficiency, hope and recovery. Mindfulness and relaxation techniques, including imagery, all work towards child wellness. Collaboration works through shared decision-making to empower the child. By listening and hearing them and supporting a child-safe culture using Policy 162A of the Education Act. Designated time spent with staff self-care together with supervision and training help develop strategies to alleviate stressful situations, reduce burnout and avoid secondary trauma. Trauma-informed, recovery-oriented practice should be used to assist refugees in childcare centres. It is an evidence-based approach to healing and recovery of trauma. In a daycare centre, it can assist the children, their families and the wider community, allowing the children to explore their emotional world, build on their inner resources and strengths, leading to child-initiated healing. Organisations need to change their culture to understand how a trauma-informed, recovery-oriented practice within the centre will assist all the children, but in particular refugees suffering from psychological trauma. This means having the determination to change policies and procedures to achieve this goal, even if it is as simple as room utilisation and security cameras. Staff need to use a holistic approach for an inclusive, collaborative and culturally edifying program in order to identify the traumatised child's weaknesses and strengths and use them to help them understand their past and focus on a hope-infused future. They need to maintain self-care and self-regulation and teach it to all the children. Trust is a big factor in healing and recovery through trauma-informed care in daycare centres. Trust in the staff and therapists, but also trust in the refugee children, that they are capable of making choices about their lives and should be empowered to do so.